Welcome, Stuart. Stuart's Head of Clinical Development at IVC Evidensia. You're very welcome. I'm going to speak to us from guidelines to growth using care frameworks to support CPD in first opinion practice.
Thanks, Linda. Seems we're trapped over here, otherwise I'd be the person walking up and down, so probably better that I'm stuck here. Afternoon, everyone. Appreciate it's been a long day. We've had a lot of information to contend with, so thank you for sticking it out. I'll try and keep this as interesting as possible. You will see from my lack of postnomials there, I am not a researcher or an academic. I am very much a first opinion practitioner and a quality improvement practitioner, and that's going to feed into a lot of what I have to say today. So, the answer to life, the universe, and everything is 42. But what is the question? Any Hitchhiker's Guide to the Galaxy fans in the room? Today, my answer isn't 42, it's 17. 17 years. But what's the question? The question is, what's the average time it takes for new health research to make its way into clinical practice? 17 years, according to a review paper by Morris, Wooding, and Grant. 17 years between what's discovered in a lab or published in a journal and what actually happens at the patient side. Now, in human medicine, that's already a problem. But in veterinary medicine, where our patients' lifespans are measured in years, not decades, it means that most of the animals under our care will not benefit from the best available evidence in their lifetime. That's a sobering thought. So how does research actually get from the page into clinical practice? It's a bit small, sorry. Morris and colleagues describe a model that replaces guidelines as a key stage in translating clinical research to clinical decision-making. But in primary care veterinary practice, that translation step is often where things fall apart. We have some excellent consensus statements and guidelines, but they tend to share a few common challenges. They don't often cover every condition that's relevant to primary care. They're often buried in journals that busy clinicians don't have time to read. And when they are published, they're long and detailed, sometimes over 100 pages. And when updates come, they can take years. So while the evidence may exist, it often isn't accessible, relevant, or usable in the time it takes to make a clinical decision. And that's really the problem that we wanted to solve, and it's why we developed the care frameworks. Care frameworks are designed to bridge the gap between research and reality, to bring together the best available evidence, expert guidance, and real-world experience in a way that's practical, concise, and meaningful for our first opinion clinicians. The first care framework was born out of necessity from a quality improvement project on canine otitis externa. Otitis externa affects around 1 in 10 dogs seen in primary care practice. It's common, it can be frustrating to manage, and it's an area where clinical practice often varies widely. Yet at the same time, there wasn't a specific practical guideline available. When we audited otitis externa care across our network of nearly 1,000 practices, we found that ear swab microscopy was being performed in only 15% of cases, despite recommendations by the dermatologist to perform it at every visit. And we found an over-reliance on antibiotic-containing ear drops, which are being prescribed in more than 70% of cases. This is considerably higher than in Scandinavia, where diagnostic testing rates are much higher and antibiotic prescribing rates much lower. I saw a poster from a colleague recently. Norway and Finland are prescribing about 28 to 29% of the time, and Sweden only 2% of the time. We've got a long way to go. So we ran a pilot, an educational intervention focusing on improving diagnostic approaches and rational prescribing, and it worked. Teams who engaged with the support showed sustained improvements in their clinical measures. They had improved use of ear swab microscopy and reduced antibiotic prescribing rates. That success led us to the formation of a working group, a mix of dermatologists, subject matter experts, and frontline clinicians to turn the pilot into a structured, shareable resource. And I'm using word clinicians like Wendy did earlier, vets and nurses. The group's task was to develop something novel, a tool that would combine the rigor of evidence-based guidelines with the practicality of something like care bundles. Those small sets of key evidence-based interventions in human healthcare that have proven to improve patient outcomes drastically. And the end result was the canine otitis externa care framework. It distilled the best practice approach to otitis externa into 10 key recommendations grouped under 4 headings. In green, we had patient welfare, focusing on pain, fear, and quality of life. In blue, diagnostics, identifying the underlying causes of the condition. In yellow, treatment, using the most effective evidence-based therapies. And in grey, client care, supporting owners with education and follow-up. Each of those 10 recommendations was supported by rich educational content, from decision trees and flowcharts to drug charts and evidence summaries, and short instructional videos. And this became our template for every subsequent care framework. And from that starting point, the care frameworks have expanded rapidly. We've created care frameworks for common high prevalence conditions like periodontal disease, osteoarthritis, and atopic dermatitis, areas that every clinician encounters weekly, if not daily. We've also tackled less common but complex conditions such as mitral valve disease, Cushing's syndrome, and canine and feline diabetes mellitus, where there's often uncertainty or variation in management. And beyond classical medical conditions and presentations, we've also looked into welfare areas, tackling important considerations like end-of-life care and behavior first aid. Because evidence-based medicine doesn't just apply to diagnostics and drugs, it applies to how we care, communicate, and make decisions. We've now developed 20 care frameworks, each one created collaboratively by working groups that include referral clinicians, primary care vets and nurses, and client care teams. And that diversity of perspective is key. It ensures that every framework is grounded in evidence, but tested in the real world of a 15-minute consult and a busy waiting room. One of our clinicians said, "I really enjoyed collaborating with other vets from all the different backgrounds and putting together something that will hopefully really make a difference." And another said, "Client care has accessed and used resources in the care frameworks, such as end-of-life care, to act as training and support resources for their team. I think it's great how it's all joined up." Accessibility was another priority. All of our care frameworks are hosted digitally on our company intranet, available from every practice computer. So if a vet is about to see a diabetic cat or a nurse is reviewing a painful arthritic dog, the relevant care framework is only a few clicks away. Technically, our teams can also access the care frameworks on their phones, but we don't recommend the use of phones in consult rooms for infection prevention reasons. It has to be during their breaks. And because it's all digital, the care frameworks can be updated almost instantly. For example, when new medications are launched or when new evidence emerges. No need to wait years for a consensus and a revision. And compared to some of our other corporate initiatives, the response from practices has been overwhelmingly positive. We sent out a survey to better understand how they've been received and discovered to our delight that 88% of respondents were well aware of them, 71% of them rated them as either very or extremely useful, and 64% agreed or strongly agreed that the care frameworks had either changed the way they treated cases or it helped reduce the use of antibiotics in their clinics. Our graduates have been some of the most enthusiastic adopters. They tell us that the care frameworks give them confidence, structure, and a way to bring current evidence into their day-to-day work, and that they feel more confident challenging outdated clinical habits displayed by some of their more experienced colleagues. Care frameworks have become a catalyst for team development too. Practices are using them to reflect on their own cases, to review what went well, what could be improved, and how their current approach compares to the care framework recommendations. This reflection often sparks quality improvement projects tailored to their own data and patient population. One practice leader said, "We assign each care framework to a vet to go through in detail and then put together a summary presentation highlighting what we could do to improve on our current approach." And another said, "The care framework prompted us to look at our antimicrobial usage, and eocytology now plays a key role in guiding these decisions." So to support this quality improvement approach, we developed clinical benchmarking reports linked to 13 care frameworks so far. These use real-world clinical data to help practices identify care gaps and to track improvement over time. And the results are really quite impressive. In otitis externa, we've seen the use of ear swab microscopy grow from 16 to 25%. Topical steroid use increased from 10 to 20%, and antibiotic ear prescriptions dropped from 62 to 49%, representing nearly 26,000 fewer antibiotic prescriptions compared to the year before, and improved care for over 17,000 dogs. Periodontal disease, similar drops, and improved care for over 700 cats and dogs. And in feline renal disease, we've seen the percentage of cats with renal disease receiving blood pressure improve, as well as urinalysis, which led to improved care of over 600 cats. These are real measurable changes in clinical behavior, and they've happened at scale across hundreds of practices in less than a year of implementation. In fact, the combined impact of the care frameworks is now over 60,000 patients. But this also goes beyond clinical outcomes. It's helping us redefine what we mean by continuing professional development. Because traditionally, CPD has often been about attendance, how many hours, how many certificates. But I believe that real continuing professional development is the kind that improves care. It's about impact. It's about whether what we learn actually changes what we do in practice. To support that, we've aligned our approach with the Royal College's definition of modern CPD as a reflective continuous cycle with 3 key stages. The first, acquiring knowledge and skills, and the care framework serves as curated evidence-based resources, helping clinicians keep up to date in a way that's quick, relevant, and reliable. Second, applying learning in clinical practice. They're used at the point of care, helping vets make evidence-based decisions in the moment. And third, reviewing and reflecting on the outcomes. With the audit and benchmarking data, teams can see how their practice is changing, celebrate their progress, and identify where more support or training is needed. And that's how CPD becomes more than a tick box exercise. It becomes a learning loop that drives genuine improvement. So as Prof. Cake said earlier, with that triangle, Miller's does better is definitely my vote for the top of the triangle. So to conclude, the care frameworks were created to make evidence-based medicine more accessible, more actionable, and more engaging for primary care teams. It brings together research, expertise, and clinical data into one practical tool. They empower vets and nurses to make better, more consistent decisions. They foster reflective, team-based learning. And most importantly, they've demonstrated measurable improvements in clinical care and patient welfare. In short, they're helping us to close that 17-year gap, translating evidence into everyday practice and ensuring that our patients benefit from the best of modern veterinary medicine today, not decades from now. Thank you.
Thanks, Stuart. That's really impressive data. Have we got any questions from the audience? Yep, a few already.
Hi, I thought that was really interesting and would have been really useful when I graduated to have all that. I just wondered, you mentioned obviously they're easy to update. Practically, who is responsible for doing that, and how do you ensure that those updates are then kind of dissipated? Because I imagine once someone's looked at them a few times, they will have changed their practice and almost become second nature, and they then might not return to that to see those updates.
Yeah, great question, thank you. So multiple layers there. So quick updates we do as and when we need to because we can. So spelling mistakes, that kind of stuff is pretty simple and straightforward to fix. Some of the bigger changes, sort of review by committee. So we have specialists within IVC that we can go to and say, what's the agreed approach here? Or if there's new medications, for instance, that we're trying to, those we're leaving for a 3-year cycle as best we can, if they're major changes. But any minor changes, we will just ping through as we go along. As far as how do we make sure people go back and check, I don't think we've cracked that one yet. This is all quite new for us. But it's a great question, and I think especially as the number grow, and we've already got 20 going, it's very hard to say whether people are going back to the early ones and checking. So I think we're going to need to do a better job of making sure when we make changes that's made known so people are aware to check on things. Thank you.
Stuart, I think we've got one there.
Hi. So thank you. They sound like really useful tools. My question sort of is how that fits in with the idea of contextualized care, in that if there's a framework that vets are following, but how that fits in with that owner's context. So using ear cytology as an example, that's obviously going to incur a cost to the owner. So are there alternative pathways or options that vets can follow when following those frameworks?
Yeah, and we've definitely stuck with just giving recommendations rather than spelling it out. So my boss will be proud to hear me say tools, not rules is our approach. The idea is no one has to follow these, but we've got the evidence to back the way we've built them is to say that your patients should get better outcomes if you do follow them. So it's up to you, but most practitioners want the best outcomes for their patients. And if you can do the recommendations, you'll probably do better. If you can't, you're still going to do the best you can, and that is resource dependent. So, yeah. And a lot of the contextualized care stuff comes in when we're building them in the first place. We make sure that we're including vets and nurses on the ground who are seeing these cases every day and saying, what's important to you? What are these conversations that we need to be taking into account? So it's a big part of how we build them, and then also allowing some space for that.
Thanks very much. We better move on to the next session, but hopefully if there's more questions, I'll catch you later. Thanks, Stuart. Thanks.